Hello, I'm Steven Joniau. I am a urologist working in Leuven, that's a university in Belgium. And my main interest is high-risk prostate cancer and the treatment of this disease. Here at the IMUC meeting in Marseille, France, I gave a lecture on the role of surgery for high-risk prostate cancer. First thing that I want to clarify is that if you follow up without treatment patients with high-risk prostate cancer, so if you look at the natural history of the disease, you will find that many people will die of prostate cancer, and certainly in the younger patient populations, the risk of dying from prostate cancer is actually higher than the risk of dying from any other cause. Now, this is data coming from Scandinavia, where traditionally, a couple of decades ago, people were not actively treated for prostate cancer, they were followed up. So there's pretty good data showing the natural history of the disease. We have formed with major European centers and also Mayo Clinic in the US a consortium in Europe called EMPACT, the European Multi-Center Prostate Cancer Clinical and Translational Research Group. And we've collected data on almost 6,000 patients treated with radical prostatectomy. All these patients had high-risk prostate cancer, meaning PSA of over 20, clinical stage T3 or higher, or Gleason score 8 to 10 on biopsy. So one of these factors or combinations of factors were defined as high-risk prostate cancer. And we have looked especially at outcomes of surgery in this population. And very consistently, and it's consistent throughout the participating centers, the 10-year cancer-specific survival is around 90%. And if we compare that with the natural history of which I was just talking, and the Scandinavian patients, the cancer-specific survival 10 years down the line was something between 50 and 70%. So remember that, 50-70%. With surgery, we appear to be able to give these patients a much better perspective and better outcome because they have a cancer-specific survival of 90%. To be clear, many of the patients also need adjuvant or salvage treatment strategies. It's not the surgery alone who is doing the job. But the surgery as a first step in the treatment process of the patient appears to be extremely relevant and very important. If you look at reality, and there's data from, I think it's Steve Borjan, it's Matt Cooperberg, and he looked at the SEER database, and that's more like a community-based database, where he looked at the practice of how these patients are treated in real life. And what he saw was that in low-risk prostate cancer patients are treated with aggressive local treatments, radical prostatectomy in the majority of the cases, or brachytherapy or radiation, sometimes cryotherapy, and only few were treated with hormonal treatments as a primary therapy. And the high-risk prostate cancer patients were mainly treated with hormones alone. And only a minority of these patients received radical surgery or radiotherapy. And it should be the other way around. The whole philosophy of treating patients is not to treat low-risk prostate cancer patients, because there are prospective trials showing not a lot of difference between doing nothing, watchful waiting of the patient, or surgery. And these trials, this is a Scandinavian one, again, Scandinavian, and there's an American trial who have shown in the total population, at least for the low-risk patients, not a lot of benefit, even no benefit. But in the high-risk patients, these trials have shown benefit in surgical treatment for these patients. Now, in reality, even though we know all these data now, and the natural history of high-risk prostate cancer appears to be a lethal disease, patients with high-risk prostate cancer are undertreated. And so the message I wanted to give and to convey is that patients with high-risk prostate cancer should be treated actively, and surgery is probably going to be, and appears to be, a very good strategy, a very good treatment, first-line treatment for these patients.